Felly, croeso i chi gyd, os allai alw'r cyfarfod yma i drefn. Diolch i chi gyd am eich presenoldeb. Ydych chi'n sylweddoli rwan bod y cyfarfod yma yn digwydd mewn dwy iaith, a mae offer cyfieithu ar y pryd ar eich seddau chi, gwneud siŵr bod hwnnw yn gweithio. Ac dwi'n cymryd bod yn gweithio, os yna neb yn chwifio mewn stad o banig llwyr wrth i fi siarad, so felly fi'n cymryd bod y cyfarpar yn gweithio, felly gai adnewyddu felly yng nghroeso chi gyd. Diwrnod pwysig, a da ni yma i drafod dros yr awr nesaf Gwasanaethau Gofal Iechyd a Gofal Cymdeithasol yng nghefn Gwlad Cymru. Dr Teulu dwi'n aelod Cynulliad Plaid Cymru. Dwi'n dal yn feddyg teulu mewn ardal Cefn Gwlad Penrhyn Gwyr y dyddiau yma. Ond wedi ymddiddori yn y maes ers rhai blynyddoedd, fel yn amlwg mae eraill o'n cwmpas ni. Nawr, mae'r cyfarfod mae'n cael ei redeg gan Wasanaeth Ymchwil y Cynulliad wedi bod yn cydweithio efo Gwasanaeth Addysgiadol Cymru, Learned Society of Wales, ac hefyd Iechyd Cyhoeddus Cymru fel partneriad i ddod â'r rhaglenni yma ynghyd. Felly, pwrpas hyn ydy rhedeg rhai syniadau heibio chi, ac hefyd i gael syniadau newydd o'r llawr, lle bydd hynny yn briodol. A wedyn, gwn i 4 cyflwyniad byr dros rhyw 5-6 munud gan yn 4 cyfrannwr, a mwy amdanyn nhw yn y fan. Ond wedyn fydd yna ddigon o amser wedyn i chi ofyn cwestiynau am y pwnc yma o'r llawr megis. Felly, a very warm welcome to you all, and a warm welcome to this afternoon's speakers. Dr. John Wynn-Jones, who's a GP who chairs the Rural Working Party. Well, it says here, the Rural Party of the World, but then there's another line that says Organisation of Family Doctors, so it's not the Rural Working Party of the World. The Rural Working Party of the World Organisation of Family Doctors. Croeso, John. Then we have Dr. Rachel Rahman from the Centre of Excellence in Rural Health Research, Aberystwyth University. Anna Prytherch, Rural Health and Care Wales Project Manager, and Joy Garfitt, Assistant Director for Mental Health Services, Powys Health Board. Now, obviously, people will be taking pictures of this for websites. There's already been a lot of social media interventions in terms of, I've got at least 3 questions to be asked before anybody has opened their mouths, courtesy of the Twitter feed this morning. So, if you have any issues with the photography, though, I'm not quite sure, but indicate that you don't want your picture taken. You may be just a little bit shy and withdrawn like myself. I can perfectly understand it, but photography is available. Felly, without more ado, Dr. John Wynn-Jones. Tro croeso.
Diolch mawr. Thank you, Mr. Chairman. Today, my role is to speak on issues surrounding the recruitment and retention of the rural health workforce. And it's got an emphasis on the recruitment of young family doctors. However, if you look at the evidence worldwide, the literature shows that the same principles, the same issues apply to other members of the rural health workforce. I worked in Montgomery in Powys for 37 years, and I established the UK Institute of Rural Health in Grigynnog, which ran for about 15 years. The Institute contributed to Welsh rural health policy, and in particular to the Welsh Rural Health Plan. I'm now a senior lecturer in rural and global health at Keele University, and incidentally, we are one of the most successful medical schools in the country for recruitment of our students into general practice. My main activity, as Di mentioned, is that I chair the Working Party of the World Organization of Family Practice on Rural Health. And just to get you used to the word, the World Organization of Family Doctors is called WONCA. You'll see that come up a few times. And it's nothing to do with Roald Dahl. But we represent something between, I don't know exactly how many, 70 to 100,000 rural family doctors worldwide. And our role is to promote rural family medicine through 4 main areas: quality, education, research, and policy engagement. The rural recruitment crisis that we're now experiencing in Wales is a worldwide phenomenon. And I've spent much of my 4 years as a chair really involved in engaging and inspiring medical students and young doctors around the world. Without them, rural health care will not exist. There is no future without them. We've established a global network called Rural Seeds, which has utilized social media to establish global mentoring, a program called Rural Success Stories, and we have an international networking process through what we call Family Medicine Rural Cafes, which uses Google Hangouts, FaceTime, and other social media opportunities. Rural Wonka, which is what I chair, works also with other NGOs, and we have a very close relationship with the Human Resources Directorate of the World Health Organization, and we've worked with them for many years. I've just returned from Dublin, from the 4th WHO Global Forum on Human Resources for Health, and I'm proud to say that we've been able to influence the Dublin Declaration that all member countries actually sign up to, which makes a direct reference to the importance of investing in rural practice. The global population is 48% rural, yet it's only cared for by 33% of the world's nurses and 24% of the world's doctors. And if we're going to achieve universal health coverage, which is SDG 3, if you're aware of that, then we're going to have the biggest challenge will be in rural. And in Wales, the biggest challenge will be in rural. Wales is a rural country. Statistically, 30% of the Welsh population live in rural areas, and it makes it probably the most rural country in Western Europe. The recruitment crisis has been a long time coming, and it isn't over yet, because if you look at the current age distribution of family doctors in Powys and in other parts of rural Wales, it's really quite scary. Other Welsh rural issues are a disproportionate ageing population, and the projected figures for Powys are really frightening. So if we're not able to cope with non-communicable diseases now, we are certainly not going to be able to cope with the model that we have. Primary care services in Powys and certainly in Mid-Wales are close to breakdown and collapse. Some of the supportive infrastructure and the educational work that we put in at the Institute has now disappeared. And the number of GP registrars training in rural Mid-Wales has dropped. So, briefly, what can we do? What are the solutions? I understand things are happening, and they're happening slowly, but we need to speed them up. 2 major themes before I come to solutions. First of all, we've got to develop a workforce that is fit for purpose. We must look at the scope of practice. Just giving generic training doesn't equip people for the challenges they're going to get in rural practice. We need people to run our community hospitals, to manage emergencies, because ambulance times are really woefully poor. And we need people to be able to meet the challenges of rural practice and the responsibilities. We also need training programs that are socially accountable and transformative. We need to identify what the health needs of our patients are, and we need to go out there and find what kind of doctors, what kind of health professions do we need. There's plenty of evidence, there's plenty of research worldwide, and there are workable solutions. And please, please don't reinvent the wheel in Wales. There are 3 areas of action. First of all, and I'm really glad to see this happening, but we need to speed it up, we need to recruit young people from rural areas in Wales. I'm told that this is happening, but in fact, this is the thing that's going to make the biggest difference. Secondly, we introduce substantial rural exposure in undergraduate training. And I'm really delighted that, in fact, Cardiff is now embarking on what we call longitudinal placement. So well done, Francis, and you've done a great job there. But there's a lot more to do, and we need to get people working for periods of up to a year in rural Wales. And thirdly, we need to develop a postgraduate training program where doctors and other professionals are trained to meet the challenges that they will encounter in rural practice. We've got to have that postgraduate. We almost had it, but we've lost it. Generic training, as I said, doesn't work. Finally, In the IRH, we came up with the concept of the rural campus. We need to turn the rural health experience into a rural health learning opportunity. We need to develop a campus without walls and raise the academic level of our current workforce. We need people doing research, education, policy engagement happening on the shop floor. And I'm going to leave you one message, and it's worth remembering this because we have politicians here. There's some really interesting information that's coming out of World Bank at the moment. And it says that investing in rural health workforce not only invests in health outcomes, but it's been shown to be a major rural economic driver. Globally, it's been shown that for every dollar spent on the health workforce, it generates a further $9 for the rural economy. So please don't see the rural workforce as a problem. Please see it as an economic driver. So we must adopt a transformative approach to developing our future rural workforce. My suggestions will take some time to bear fruit, unfortunately, but there are urgent steps out there because the situation is really quite dire. So thank you very much, Di.
Diolch yn fawr, John. Da iawn fel arfer. Heb oedi ragor, na i alw ar Dr Rachel Rahman, Canolfan, Rhagoriaeth, mewn Ymchwil Iechyd Gwledig, Prifysgol Aberystwyth. Rachel.
Diolch yn fawr. So I'm the Director of the Centre for Excellence in Rural Health Research at Aberystwyth University, and we're an academic research centre that brings together a range of different disciplines in geography, psychology, computer science, and some of the scientists from IBERS, so the Institute of Biological, Environmental and Rural Sciences, to look at some of the challenges of rural health and social care from an interdisciplinary perspective. So part of what I'm going to talk to you about today is one of the themes of the research interests that we have around the use of technology within rural health and social care. So telemedicine has long been identified as potentially one of the solutions that rural areas should be looking to in terms of trying to tackle the challenges of inequality or reaching some of those hard to reach groups, overcoming some of the economies of scale that we have. So this goes back, so we've seen evidence of this in terms of the Longley report recommending that we implement this, but even if you go back to the Rural Health Plan in 2009, that then was advocating telemedicine as one of these solutions. And actually, Mid-Wales has a really long-standing history of telemedicine interest and research. So colleagues, for example, from Bronglais at the time, going back 10, 15 years, were invited out to America to learn about some of the innovation that was happening over there in terms of telemedicine services, and brought that back to Mid-Wales with a view to being able to develop services, and were one of the first services in Wales to be able to link multidisciplinary teams in the context of cancer. Since then, Meddyg have made extensive progress in terms of some of the telemedicine projects, and I'm now aware of various pockets of activity, of pilots and innovation in most of the health boards across Wales. But it is striking that despite all this activity, this very little that has actually made it into mainstream service is a routine practice that we're seeing across the board. And so this potentially then begs the question as to, well, why are these things sitting as pilots and not managing to be rolled out into mainstream practice? So part of the research that we've been doing at Aberystwyth is to look at some of the barriers to implementation, some of the ideas about looking at pockets of research and looking at how those work. And pretty overwhelmingly, patients are very positive about the services. They find that they provide them with reassurance, they provide them with more continuity of care, they provide them with a decrease in the need to travel to access certain things. So it seems unlikely that patients are the stumbling block in terms of dissatisfaction, in terms of why this is happening. And I'm sure plenty of you will have your views as to why this might be. I'm just going to propose a few that from our research might suggest some areas. Partly, I suggest that this is down to a really inconsistent technology infrastructure in our rural areas. So what we're seeing is such poor broadband access that actually the real people you want to reach, those real hard to reach communities, the most vulnerable in our communities, aren't actually being able to make use of the technology and the innovation that we're seeing. This is also meaning that the clinicians or the healthcare professionals who are having to implement these services have a real distrust in the technology, because increasingly it falls out. You have a patient on the other end who you're not able to confidently access, and these medical professionals are then spending their time being the tech support, trying to resolve technology issues, as opposed to actually engaging with their patients in the way that they want to do that. We also see increasingly that the drivers in terms of the financial incentives to try and get things happening in terms of technology often focus very much on the equipment that you can buy, capital spend to buy the equipment. And this can result in two things. So you often have managerial people scrabbling together competitive bids to try and get some access to equipment. But often this has meant that there hasn't been adequate time to really consult with the people working on the ground. So what you often see is kit being bought that the actual people on the ground don't really see the purpose of, or don't really feel that it's hitting the need within their service. So they end up sitting in boxes, in pockets of rooms, never even being opened or used. You also don't have the buy-in from the staff on the ground in terms of doing that. But more importantly, I think, the problem with this approach to consistently funding new equipment is that there's often never room to employ a member of staff. And by the staff, I don't necessarily mean increasing your clinical or healthcare team. I mean it's about somebody who's there to support you in delivering telemedicine services. Somebody who's going to champion it, who's going to help make sure the technology is working. The tech support in the research that we've done within the hospitals isn't adequate to be able to support and champion this kind of research for staff. And increasingly, they're spending their time having to decide whether or not it's easier for them actually to get people into a clinic as opposed to fiddling with the equipment to set this up. So we need to look at how we might be able to support our staff better. And finally, we need buy-in from our urban colleagues. If what we're talking about is setting up multidisciplinary teams, potentially accessing tertiary centres, we're reliant on our urban colleagues to have that same buy-in. There's no good everybody in rural areas thinking this is a great idea, but increasingly seeing that actually our urban colleagues don't see the benefit in this and not providing that expert support potentially, because for them they're not necessarily considering the increased effort it takes our rural patients to travel a 2.5, 3 hour trip to Cardiff for a 10-minute consultation before they return home. However, I welcome your views.
Thank you. Diolch yn fawr. Cyflwyniad arbennig arall, diolch yn fawr iawn i Rachel. Nesa ydy Anna Prytherch, Rheolwr Prosiect Iechyd a Gofal Gwledig Cymru. Anna.
Pnawn da. Oops. My name's Anna Prytherch and I work for Rural Health and Care Wales, which is, maybe a lot of you haven't heard of it. It's a relatively new organisation that was set up by the Mid Wales Healthcare Collaborative. It was the 12th recommendation from Marcus Longley's Mid Wales Healthcare Study. It was launched last year, but we've been primarily active this year since the beginning of the year when staff was employed. It's supported by Betsy Cadwaladr, Powys Teaching Health Board and Hywel Dda University Health Board, in addition to the local authorities of Ceredigion, Powys and Gwynedd, and also the universities of Wales, so it's Aberystwyth, Swansea, Bangor, Coleg Cymraeg Cenedlaethol and Trinity St David's. It's a three-pronged, really, approach to what we do. The first is looking at the recruitment and retention of not just healthcare, but also social care professionals in rural areas of Wales. The second aspect then is staging events that relate to rural health and care. And we've recently had a very successful conference that was held on the Royal Welsh Showground at the beginning of the month, which I'll tell you a bit more later. And then the third one is to undertake research. So we've worked closely with Rachel, but we're also doing individual research, which is like blanket research, looking at the recruitment and retention of nurses. We're funding a PhD student that's at Aberystwyth University who has undertaken research there. We've also done assessments of the population assessments collaboratively across the Mid Wales sector and other pieces of work. It's not all doom and gloom in rural areas of Wales, despite what you might have heard so far. So I was going to quote you some figures that says, you know, if you do live in rural areas, that your life expectancy is marginally higher, infant mortality is lower, and that there are consistent improvements in well-being measures. For example, life satisfaction was measured at 7.82, and these statistics are as recent as August 2017. Whereas within urban areas, it's 7.61. People feeling that their life is worthwhile, 7.92 in rural areas, 7.81 in urban areas. The happiness factor, again higher in rural areas, 7.76 as compared to 7.45, and anxiousness is decreased. So if you're living in rural areas, generally on a par, your anxiousness levels 2.73 compared to within urban areas is 2.98. So it's not all doom and gloom in rural areas of Wales. What are the issues that we face? What we face primarily relate to the access to healthcare, which has already been mentioned. And that's in terms of the infrastructure. So there's transport costs. There's also the broadband infrastructure, which Rachel's referred to. And then access to specialist treatment. We've only got one, for example, we've only got one district hospital within the whole of Mid Wales. So there's a lot of community hospitals, but only one district hospital. So people from Powys, for example, are travelling to Shrewsbury or Telford. The option is Pronglais, and then South Powys, they might be going to Abergavenny or Hereford, as opposed to then the Hywel Dda centres in Carmarthen. So the logistical issues relating to care in the community as well, in terms of cost to deliver healthcare and social care services in rural areas is going to cost you more because of the travel involved and also the time. There's communication as well. I think there's communication issues, and the linkages between social care and healthcare need to be improved to facilitate or enable better services to patients. The demographics in rural areas, it's an elderly population, as John mentioned, and with that we have a high percentage of dementia sufferers, which Joy's going to talk about later. There's also the loneliness factor and social exclusion, which is affecting a lot of people. We've heard already about the recruitment and retention of health and social care professionals. At the conference that we just had, there was an interesting paper delivered that quoted up to 60% of GPs and doctors work within a 20-mile radius of wherever they did their training. We don't currently have doctors' training in rural Mid Wales, although we're going to hear some more about that in a minute. Access to local education, again, John mentioned that in terms of what training is there available, not just to doctors, but to nurses. Currently, anybody in Mid Wales who wants to train to be a nurse, they might have family, they might be mature entrants to nursing, or they may be re-entering the profession, are having to travel down to Carmarthen, which might not seem exorbitant to you, but you add a 2.5, 3 hour journey to your working day, and it's quite considerable. And then the other aspect that we've identified with the education and training is lack of recognition of the skills that are required by rural healthcare and social care practitioners. There is that generalist idea, and it's often looked down upon, I suppose, in some instances, and this is something we've come across when people are working in rural practices, whereas in effect, maybe your skill set is even broader than those who are working within specialist urban healthcare centres. So those are the challenges in a nutshell. The opportunities then that we have in rural areas. Initially, I started off mentioning well-being factors and the health impact of living in a rural area. So the opportunities relate to that. We can maximise the health and well-being of the people that live in rural areas and divert maybe to considering green, blue or social prescribing. These are the new terms in terms of improving well-being or looking at mental health issues by, instead of having medical interventions, to consider social interventions, to consider green prescribing and blue prescribing, to those that don't know, that relates to water sports or water activities or coastal activities that have been seen to have an effect, a very positive effect on people who don't necessarily need to have that medical intervention. We can build on the strong communities that exist in rural areas. Again, there was another talk given at the conference from Solver Care, who have an excellent community group of volunteers who look after their own, in effect, by providing those additional services that provide transport, that provide company, that provide small tasks that can be undertaken, and that alleviates the burden, the cost burden, if you like, that comes from the NHS. We can look to the rural area and promote the positive aspects to attract professionals that are looking for that all-important work-life balance. And this ties in very well with the Welsh Government Train, Work, Live campaign that's been ongoing for some time now. There needs to be better integration of health and social care provision. I've already mentioned the communication that needs to be enhanced. There needs to be a better integration of both types of services for patient benefit. We can share rural experience and best practice. As John mentioned earlier, there's so much research already been undertaken into the issues that rural populations face. And there is a commonality across them all. And that stems from the work that's been undertaken in Australia, up in the Isles of Scotland, in parts of England, etc. We can look at new roles. We've already heard of physician associates and nurse practitioners, and these are developing roles, and maybe it's time to look at the range of healthcare and social care professional roles that we have in existence to see if we could develop new roles that would bridge the gaps and deliver essential services. We could look to have a recognised rural specialism within healthcare. And again, that's been referred to, but that is something that needs to be pioneered and taken forward. Broadband connectivity, again, despite the promises that we've had, rural Mid Wales still suffers from broadband black spots, where there's huge areas where we don't have that connectivity, and therefore we cannot tap into advances in telehealth and telemedicine. We can develop local education and training opportunities. When I say local, I mean that they are rural-based. And I know Francis has been mentioned once, but Francis sits on the management group of Rural Health and Care Wales, and Cardiff University School of Medicine has just recently developed a project called CARER, whereby third-year medical students will be placed with rural GPs, starting from September 2018, and I understand that the cohort for next year, the first year, is actually full. And this will be a big positive impact on recruitment to rural areas if you relate it back to that 60% figure that I gave you initially that stemmed from research presented at our conference. In addition, Swansea University is looking to develop a primary care academy, and they are considering having a 2-year rural placement as part of their postgraduate programme. The other point I've commented, and this is a personal one that I'm making on behalf of people that I've spoken to across rural Mid Wales, is there is a dire need for a Mid Wales School of Nursing. We need to get another healthcare centre established in Mid Wales or within a rural area as soon as possible. I've mentioned briefly the conference that we held. It was attended by about 180 attendees. There was a lot of very interesting research presented at the conference, and the papers are available if anybody wishes to see them on our website. The conference was opened by Chris Jones, who is the Interim Chair of Health Education and Improvement Wales. We had plenary speakers, and it was very pleasing to see that our live Skype link with Nigel Edwards of the Nuffield Trust was successful, so that did demonstrate that sometimes the broadband does work in Mid Wales. There was a broad range of presentations available that ranged from GP training in rural areas, the use of blue and green spaces for health benefits, the role of paramedics in rural areas, telemedicine, digital technology, the use of apps in maintaining health, perinatal mental health services, dementia, and so much more. The feedback from the conference has been excellent, and there is a big call for more events such as these to continue in the future. So with that, I will answer any questions later and leave it there. Thank you.
Diolch yn fawr iawn i Anna Prytherch am gyflwyniad arbennig a'r cyflwyniad ola gan Joy Garfitt, cyfarwyddwr cynorthwyol y Gwasanaeth Iechyd Meddwl, Bwrdd Iechyd Powys. Joy. Rhowch groeso, Joy.
Diolch yn fawr. I'm going to speak this afternoon from the perspective of an organisation which is on a journey to understand what excellence in rural healthcare looks like. We're not there yet in Powys, but we're determined that we will redesign and redevelop our services to really meet the needs of our population. So specifically on mental health. Back in 2009, Powys Teaching Health Board transferred the delivery of our mental health services to 3 neighbouring health boards in order to improve service delivery. And this was on the assumption that attaching our rural services to a larger organisation would improve quality, improve our ability to recruit qualified staff and provide a much more resilient service. And over that time, some benefits were realised. However, there were still many service deficits. And in 2014, Powys made the decision to bring our services home and to directly manage mental health service delivery ourselves. I should add, just in case any of my partners are here, that this wasn't because our NHS partners couldn't provide the service our patients needed or that they didn't try hard enough, but because in our experience, a large rural area such as Powys needed a tailor-made rural solution for our service. So just to put Powys in context, from north to south, I'm told that it's a similar distance from the Severn Bridge to Marble Arch. Although, given that Powys only has about 4 miles of dual carriageway, it makes progress somewhat slower. Powys covers a quarter of Wales and is the most sparsely populated county in England and Wales, and we're about 3% of Wales's population. And Powys is also stunningly beautiful. I would say that because I live there. But it's also a challenge geography in which to deliver a traditional mental health service. Therefore, a typical urban service model doesn't transplant well into a rural area. Rather, we need a made-in-Powys solution for Powys. We're on the journey of understanding and designing a model of rural healthcare, and the first steps of our journey have been to bring back our service delivery to Powys. While this sounds simple, we've been on a 3-year programme to achieve the full repatriation of mental health services, and we completed this in June this year. We had 3 key areas of learning, and the first of which was around understanding our citizens' needs. The decision to repatriate services was taken following extensive consultation with patients, their families and our staff. Patients told us that travelling out of county was difficult and at times distressing, and our service model has sought to minimise travel wherever possible. Predominantly, we've been doing this by improving our crisis intervention and our community-based services. Secondly, recruiting to our medical, nursing and mental health practitioner vacancies has and continues to be difficult, but we've found it's not impossible to attract skilled and dedicated people to Powys. Within our adult mental health medical vacancies, traditional ways of recruiting haven't worked. That is, the glossy adverts in the BMJ and the swanky websites. Rather, our approach to recruitment has been relational. Our main successes in attracting substantive psychiatrists to Powys has been through investing in our locums to discover the benefits of Powys. We've built a relationship with them, and many have stayed with us on a permanent basis. Essentially, we had a wooing campaign for medics in Powys. We have carved job roles to meet candidates' needs and aspirations, and we've been actively supporting our middle grade doctors on their journey to become consultants, and we've been flexible in giving them the experiences they needed to achieve this. One significant barrier to repatriating our service was the challenge of operating a full out-of-hours mental health service with the relatively small numbers of staff and huge geography to cover. The solution to our challenge lay with our frontline staff, and it was to them we turned. We established working groups that cut across hierarchy to form task and finish groups. We had nurses, social workers, consultants, managers, unions, all working together. Staff members' rank or status was irrelevant to us, and we worked on the basis that if a team member could be part of the solution, then they were in on the project and they had to share responsibility for the outcome. We held 9 months of fortnightly workshops, project groups and plenty of problem solving and pragmatism. The result of which was we delivered and developed a specific POWIS model for our out-of-hours service delivery in mental health. This was the final piece of the jigsaw, and we transferred the last of our services from Ynnew Bevan to POWIS on the 1st of June this year. It's unlikely that our out-of-hours service model of mental health would work in Cardiff or Newport, but for the first 5 months of its delivery, it's been remarkably successful, and we continue to monitor, evaluate and refine it as we progress. So in terms of initial results about our service changes, over the last 5 months, our length of stay in bed occupancy in adult acute services has reduced. There's a greater ownership amongst our staff to proactively manage unscheduled care during normal working hours, which has reduced the need for out-of-hours crisis management. No self-POWIS patient has needed to travel out of county for their mental health assessment or admission to an acute ward since June. And I can't underestimate how big that has been, because before June, all patients needing admission at night had to travel to, into Gwent. And we sense an increased level of staff satisfaction, positivity and a sense of purpose, including permission to innovate. And with all the rules and the governance structures in the NHS, sometimes the permission to innovate is one of the harder areas to enable and encourage our staff to develop. So, looking to the future, we are still at the beginning of our journey to develop a made-in-POWIS mental health model of service. We've completed the first few pieces of a very large and complicated jigsaw, and we're continuing this work to design a model of healthcare fit for and with our communities. As I mentioned at the beginning, we're in this early stage of development, and we issue an open invitation to join us on this journey of understanding and developing a truly rural model of mental health care.
Diolch yn fawr iawn, Joy. A wedyn, i'r saws chi wedi troi fyny chydig bach yn hwyr, jyst i egluro unwaith eto, da ni cyfnewid syniadau ydy'r syniad tu ôl yr cyfarfod yma, a'r heriau a'r cyfleoedd sydd ynghlwm wrth ddarparu gwasanaethau Gofal Iechyd yng nghefn Gwlad Cymru. Ac fel dydych chi ar y dechrau, da ni'n ddyledus iawn i'r Gwasanaeth Ymchwil y Cynulliad a'i partneriad Iechyd Cyhoeddus Cymru a Cymdeithas Ddysgedig Cymru ynglyn â threfnu y cyfarfod bendigedig yma. Ac hefyd, mi falch croesawu Wynn-Jones, llef llywydd y cynulliad, yr aelod cynulliad dros Ceredigion yma, ac hefyd Lee Waters, aelod y cynulliad, ac hefyd Eluned Morgan, aelod o'r cynulliad hefyd yma i'r trafodaethau. Fel ddydych chi nawr, mae gyda ni ryw hanner awr i gael cwestiynau o'r llawr. Da ni wedi cael, fel ddydych chi ar y dechrau, rhai cwestiynau o le mae'r band eang yn gweithio yng Nghaerdydd. Mae yna rhai cwestiynau wedi cyrraedd eisoes dros y rhyngrwyd i fan hyn, ond mae'n naturiol i adael y cyfle cyntaf ddod o berson byw oddi ar y llawr, felly pwy sy'n eisiau gofyn y cwestiwn cyntaf un panel o arbenigwyr ni. Nid yn aml mae'r fath gasgliad o arbenigedd yn yr un stafell, felly mae'n yma chi'n neud yn fawr o'r cyfle. Wynn-Jones.
Diolch. Fendigedig cael cyfle yma i drafod iechyd gwledig yn Mae Caerdydd ac i ddylanwadu yn uniongyrchol ar bolisi o profiad y bobl yma. Ni jyst eisiau dweud un peth gyntaf, wedyn gofyn cwestiwn. Y peth cyntaf ni eisiau dweud oedd mor falch ydw i glywed am y datblygiadau sydd nawr ar fin cyrraedd i hyfforddi ac i addysgu meddygon yn Aberystwyth ac yn Mangor yn y prifysgolion yn y dyfodol. A dwi'n credu fod hwnna'n datblygiad eithriadol o gyffroes a phwysig yn mynd i fod ar gyfer datblygu'r gweithlu yn ardaloedd gwledig. Ac felly mae yna gamau yn digwydd yn hyd-destun meddygon, ond fe nath anagyfeirio at yr angen i ddatblygu yn maes nyrsio hefyd, a hyfforddiant nyrsio, a gwneud hynny mewn sefyllfaoedd gwledig. Dwi'n gwybod fod hi'n falle'n haws i bobl sy'n mynd mewn i nyrsio ifanc iawn i fynd bant i goleg i Aberystwyth, i Abertawe neu i Gaerdydd neu le bynnag i wneud hynny, ond mae nifer y nyrsys yn cychwyn i hyfforddiant yn hwyrach yn eu bywyd gwaith nhw, ac ac felly mae mynd i Abertawe neu i Gaerdydd neu le bynnag yn anoddach iddyn nhw'n ymarferol ac felly'n rwystyr. Felly ni jyst eisiau gofyn i'r panel os gyda nhw unrhyw sylwadau a beth yw'r camau ymarferol nesaf sy'n angen i cymryd i ddatblygu yr syniad yma o addysg wledig ar gyfer nyrsys.
Diolch yn fawr, Elin. Pwy sy'n eisiau cymryd hwnna ymlaen? Anna.
So just gweud, ar un adeg, fi o'n nhw'n dysgu nyrsys yn ysbyty Bronglais, yn y Canolfan, a dwi'n credu, o siarad y pobl, mae lot wedi annog bod rhyw ffordd neu gilydd, bod yna rhyw buddsoddiad mewn datblygu ganolfan nyrsio yn gwmws fel bu oedd e. Ar hyn o bryd, mae fe'n anodd iawn i pobl, maen nhw wedi gweud, hyd yn oed bod nhw'n gwneud yr hyfforddiant yn Aberystwyth, maen nhw'n gorfod trefeili lawr i Gaerfyrddin neu Abertawe i gwneud y gwaith academig, a mae hwnna'n rhwystrig iawn i bobl sydd eisiau fynd at y nyrsau, bod teulu gyda nhw a bod nhw eisiau aros yn yr ardal. Hefyd, os bod ni yn rhoi hyfforddiant i bobl lleol, maen nhw'n mwy debygol o aros a gweithio yn yr ardal gwledig.
Joy?
A significant percentage of our mental health nurses in Powys trained in the days of the Mid Wales Hospital when that was still open. Now, I don't hark back to the days of large institutions, far from it, but it was successful at providing a community-based, work-based learning experience for people to become qualified registered mental health nurses. And we need to find a new way of doing that again. In Powys, we've got the grand total of one trainee in training who's a healthcare support assistant sponsored by the Health Board, and it's a drop in the ocean compared to what we need. So we need to partner with the universities, but they need to be flexible as well as us and provide opportunities for learning by video conferencing, being able to keep people in Powys, in Gwynedd, in North Wales, in their communities, training on the shop floor of our wards and with our community teams without having to do that travel. And by far, the largest proportion of people who want to train to become qualified nurses and social workers and all of the other allied health professionals, we need to avoid that travel because they've generally got families, mortgages, etc., and they need to be rooted where they live.
Okay, John, what about Tebyg and Meddygfeydd and Amlwg?
Thank you. I think it's crucial, and there's a lot more work that's gone into medical workforce than there is into nursing workforce, but actually it's catching up. And again, there's some interesting stuff coming out of Australia. I was aware in Dublin, speaking to people from lower middle income countries, more so than even in rich countries, that actually we can use the technology. There are examples of training, nurse training, and probably, we may need to develop the developing world concept of community health workers. And it may be that's one of the things we're going to have to do to manage the crisis. But even when those people actually go into nursing courses, they're trained in that generic process. And we actually need to kind of have this concept of a rural nurse. There's a really interesting work happening up. It started in Queensland, it's spread across to Australia, of the rural generalist, and that's in medicine, where in fact they are still family doctors, but they have extended roles. And I met the chief nurse for Queensland and also for Australia in Dublin, and they're beginning to look at this in nursing as well. So I think it's actually specialist nurses, and we need to train them for rural practice, and they'll stay in rural practice.
Okay, lots of questions now, so moving on. Don't feel as though everybody has to answer every question, team. Lee Waters next.
Thanks. I'm Lee Waters. I'm the Assembly Member for the Llanelli constituency. I just want to pick up on Joy's point about using technology. Clearly, digital, I think, has got huge potential to change the way we do the health services across the board, for rural in particular. And if you can tell us what you think are the practical barriers we need to overcome to fulfill its potential.
Go for it.
We need improvements to mobile signals. We've rejoiced at the village of Stay Little recently went from no G to 4G, and we all clapped and were delighted. yet a huge part of Powys don't get any signal. What we need to be able to do is to do very good wireless coverage across the patch. That would enable some of the developments we're doing in terms of WCCIS, the Integrated Health and Care record, which we're piloting in Powys. That will make that, the functionality of that, truly a game changer for us. At the moment, though, huge parts of Powys don't have the types of connection we need, and we're a bit reliant on the wind in South Powys changing to blow the 4G signal over from Merthyr, and when it changes, it goes away again. So it's too unreliable.
Oh, is that how it works? Rachel?
I can't echo that enough. However, I think there's also something to be said about a bit of a sea change in terms of how we support and educate staff in terms of rolling this out. So we can't just expect that innovative new technology appears and our clinical staff are going to know how to use it. They're stretched, they're busy, they haven't got time to be the person having to organise all of this. And so until we have people in post or technical infrastructure within our health boards designed to be able to help and support that, I think we're banging against a really challenging door. And I also think it's a big ask of our clinical colleagues that any telemedicine type services that are added are done over and above their usual clinical time. So until we start to see this as a norm, whereby we have telemedicine clinics running, and people are provided with the time to be able to run those, I think there's a lot more we could be doing to help support our staff in terms of
Briefly?
Yeah, briefly. Sorry, a bit of a damper here. That there's a saying in America that telemedicine is the answer, what are the questions? And I think we mustn't get hung up on technology. I think it's really important that we look actually at using telemedicine as a tool rather than as a replacement. And I've got great concerns about that. But, you know, it has got very valuable services. The problem is, how do you schedule it into an ordinary working day? And really, it's not going to kind of relieve the workload that people are suffering from at the moment. So, yes, it's a tool, but I think we just need to use it as a tool.
Okay, moving on.
Hello.
Mae yna microphone yn rhywle. There we are.
Hospice UK, just yn ddigon ar rai o'r issues sydd wedi cael eu cyfro fan hyn. Oedd gen I gwestiwn ynghylch defnyddio technoleg, a dwi'n clywed o'r rwystrennau mae'r panel wedi sôn amdano nhw. Mae lot o be ni wedi sôn amdano fe heddiw ynghylch hyfforddiant I feddygon a nyrsys sy'n dechrau ar eu taith nhw. Ond beth wedyn am y gweithlu gwledig sydd yn gweithio'n barod, rheini sydd ar lawr gwlad. Oes modd I ni ddefnyddio technoleg felly I rannu syniadau ac I fod yn rhan o datblygiad proffesiynol parhaus i'r gweithlu yna. A dwi'n meddwl yn benodol am fodeli sy'n defnyddio canolfan arbenigol I ledaenu gwybodaeth arbenigol mas i'r gymuned. Dwi'n gweithio ar gyfer Hospice UK a ni'n defnyddio, mae yna brosiect yng Ngogledd Iwerddon ar hyn o bryd o'r enw Prosiect Echo, lle mae yna hosbisau mewn ardal gwledig a maen nhw wedyn yn cysylltu mas gyda cartrefi gofal sydd â phobl sydd yn derbyn gofal diwedd oes mas yna. Ac mewn ffordd wedyn o ddal clinigau ar y cyd felly I ceisio datrys problemau. Os rhywbeth fel yna'n digwydd gyda ni yng Nghymru, oes cyfleoedd gyda ni yng Nghymru ddefnyddio'r math yna o dechnoleg?
Can I diolch? Pwy sy'n cymryd hwnna? Rachel?
Oes. I ni'n edrych mewn ar hyn o bryd ynglyn â dwi wedi bod yn gwneud rhai gwaith gyda'r grŵp yn Bronglais yn Tŷ Geraint yn edrych ar cyfleoedd I mynd allan I tai bobl, bod ni'n lincio bobl o'r tai nôl i'r criw gofal diwedd oes. Ond ni hefyd yn edrych ar gweithio gyda rheini yn yr Alban sydd yn eisoes yn gweithio yn y ffyrdd ych chi'n sôn. Ac yn edrych ar sut llwn ni mynd allan i'r gymuned yn fwy. Ydych chi'n iawn yn ogystal ar bydd yna i'r cleifion, mae yna bydd ofnadw i'r bobl sydd yn eistedd gyda'r claf ar yr ochr draw o ran y dysgu maen nhw'n gallu wneud oddi wrth yr arbenigedd yna. A dwi ddim yn meddwl bod ni wedi dal hwnna cweit eto o ran ymchwil ynglyn â faint o hyfforddi sydd yn digwydd yn eitha anffurfiol trwy gallu gwrando ar yr arbenigedd yna sydd yn cael ei gyfleu.
Symud yn ymlaen i Ceri. A wedyn Paul.
Helo, diolch. Ceri Williams o Gofal Cymdeithas Ddysgedig Cymru. O'n i moyn holi mwy am oedd chi wedi sôn Anna ynglyn â bod angen swyddogaethau newydd yn Cefn Gwlad i wedig, ac mi'n credu fel yn ni deall i llenwi'r bwlch rhwng Gofal a Iechyd a gwasanaethu pobl yn well. Felly, allech chi sôn fwy am rhai o'r swyddogaethau newydd mae chi'n gweld yn wedig o'r ochr Gofal a Iechyd, a falle gweddill y panel fyd. Diolch.
Dwi'n siŵr o beth yw'r term Cymraeg am Physician Associate, ond mae rhain wedi dechrau'n barod. Ni wedi cael sawl un yn Cefn Gwlad yn y blwyddyn diwethaf, ni wedi cael 4, a fi'n gwybod mae rhain wedi dod o Birmingham, ond fi'n credu mae Abertawe hefyd yn gweithio nawr i greu criw o Physician Associates i ddod i gweithio yn Cefn Gwlad gyda ni. A mae hwnna'n cam mawr o ran cefnogi'r gwaith mae'r doctoriaid eu hunain yn wneud. Mae dyn ni sawl rôl hefyd gyda'r nyrsys sydd yn datblygu, a fel oedd John yn gweud, mae angen falle edrych ar hwnna hyd yn oed fwy, datblygu arbenigedd mewn bod yn nyrs mewn ardaloedd gwledig, achos bod angen sgiliau mor eang arnynt ar hyn o bryd, ond mae hefyd nurse practitioners ar gael, a mae rôl y nyrs yn datblygu, ond falle bod eisiau datblygu fe hyd yn oed yn fwy o ran pobl sy'n byw yn ardaloedd gwledig.
John?
Yeah, look, I'd go back to say that, I think we should really seriously look at what's happening in the developing world for community health workers. And there's some really interesting stuff, certainly in mental health, about community health workers delivering CBT. And in fact, a colleague of mine who works actually, who's a professor, and he also has a research unit in Sri Lanka, says that actually his patients in rural Sri Lanka have better access to mental health services than not in Powys, but in parts of England. So I think we should be looking at that. There's one, again, sorry, I'm coming up with words of caution here, that in fact I phoned around a lot of colleagues last night, and one of them said, actually the difficulty when you've got these big teams, as the GP, and whether you like it or not, you're the nominal head of that, you're managing risk in the sense that these people are replacing people who'd look after their own risk. So just caution that actually we need to make sure that we've got the risk element right here.
Okay, diolch yn fawr. Paul, is that?
Paul Worthington, I'm a freelance health policy researcher. Very interesting what both you, John and Anna, said about the more generic, general rural specialist. Because obviously the pattern in professional development has been you go and specialise in areas like diabetes or end-of-life care. So it's almost a counterintuitive way of doing it, but I actually think it's a real necessity for rural healthcare. But it raises issues of job description, scope of practice. How is that going to happen? Who's going to lead it?
Would you come around? You're the rural GP of the world.
Well, yes, I mean, there is a need to do this. How it's going to be set up, I'm thinking we're going to have to leave it to our politician friends because, but it's interesting in Australia, it's come out of the medical schools because they actually also do postgraduate training. So essentially what's happened with the generalist program there, it's a 4-year rather than a 3-year training. So they take on a procedural skill as part of that training. The really interesting things, if you take parts of Australia that have struggled for decades to attract doctors, up in Queensland now, they're full. And the really bright kids from the universities are going into rural generalism. That's a huge step forward.
Good. Matt.
Hi, Matt O'Grady from the Stroke Association. Obviously, providing services to people is going to be very important, but also thinking about prevention and how we detect when people might be ill as well in rural areas. we do a lot of work around blood pressure checks. We do annual blood pressure checks at the Royal Welsh Show, and a lot of the people who attend those say that's pretty much the only time they actually get it done per year, because we know how difficult it can be to access some of those health services. And also one of the ones we're particularly concerned about is things such as atrial fibrillation as well, and which is a nice, quick, easy pulse check, and making sure people are getting those. So it's how we can perhaps, do you think there's a role for better using some of the other health services people might use, such as pharmacies, for example, things such as other treatments that people might get? I think it's chiropodists, for example, can do pulse checks as well. How do you think that there's a role for better using those when we know that actually accessing services is going to be so much more difficult in rural areas? Can we make better use of those things people can access instead? Do you think that could be a solution?
Okay, thanks, Matt. Who wants to kick off on that? Anna?
I would say that that's essential, and it is taking place currently within pharmacies. They are offering, I know around in rural Mid Wales, you can get your blood pressure, but it's maybe public perception that also needs to change. And I think this links again with the social prescription and the green. There's so much more that can be undertaken, maybe outside the traditional medical route, that could ensure your health and well-being is maintained. So yes, within pharmacies, within maybe community centres, I think the defibrillation machines as well, that has kind of raised that people are taking ownership now within communities of healthcare more and more. And I think a social prescribing is another big element that will come into that as well.
Okay, John?
Put them everywhere, you know.
Yeah.
Blood pressure is not the domain of, blood pressure managing is not the domain of us healthcare workers, it's actually everybody's. But the most important thing, in your pocket, you've probably got a smartphone that is going to change the way entirely we look at monitoring our health.
Yeah, because you can measure your pulse now, and some of them are measuring your blood pressure as well, but I'm not promoting any particular system. Any other questions? Before I can always resort to our online questions. Let's have one of those then. Given the crucial role that community organisations play in social care, how can they be properly integrated into local and regional strategies? That's a question from Sue Denman, who's trustee of Solver Care. Given the crucial role that community organisations play in social care, how can they be properly integrated into local and regional strategies? Sue Denman, trustee of Solver Care, Pembrokeshire, presumably. There's only one Solver. Who wants to take that one on?
Shall I just?
Go on.
We need to do more commissioning of the third sector and voluntary organisations to deliver services for us. In Powys, we've been working, in South Powys, working with Mind over something called active monitoring, which is supporting people with lower level mental health difficulties in GP practices, and it tends to be the patients who would frequently attend their GP with anxiety or distress will go and see an active monitoring practitioner. Early days on that seems positive. One of the difficulties we have in Powys, and we're not unique in this way, is how we get consistency of provision across our patch. And what we need the voluntary sector to do, and what we need to be as an enabler to the voluntary sector, is helping voluntary organisations join up, collaborate and cooperate to provide services, so we can get some consistency of access and provision for our patients and our service users. And we need to do much more of this in the NHS and in local government.
Can I just mention a scheme that we're putting together, a pilot project for a social prescribing pilot, and hoping to get grant funding for that. And that is reliant very much on what they deem to be community connectors, which are very successful in Powys at the moment, linking that third sector, voluntary sector, to mainstream healthcare. And the intention, or the long-term aim, is that these are linked directly with maybe medical practices, with GP practices, and support that linkage role then with all the voluntary and third sector services that are available out there.
Diolch yn fawr. Unrhyw cwestiwn arall? Gwneud arall o ddi ar online. From Bill Parker, should the Bwrtsog Neighbourhood Care Scheme be introduced in Wales? Bwrtsog, it's a care scheme, a Dutch care scheme, nurses in the community. They look after between 60, 80 people by and large on a community basis. Do you want to talk about Bwrtsog, John?
I'm going to delegate to Joy or Joanna there. I'm not really...
Well, I've heard of it, but I'm not fully aware of it. I don't know. But I think the idea, again, is to link, it's that linkage between community. And, you know, I identified it in my presentation. There needs to be stronger linkages. There needs to be stronger communication. But also there needs to be these new roles. And I think these community connectors linking with nurses to take responsibility for their own patient cohorts are essential. And that's the way it will be moving forward.
Indeed, I think it's an extension of what's already happening actually with us on the ground with community district nursing now, certainly in Swansea and Gower and probably in other places as well. Another question from online is from Arona Probert. In rural areas that are close to a health board boundary, should services be offered from the nearest point? Increasingly it seems that health boards are excluding people who come from outside their area, possibly as a result of funding issues. I don't know if that's a reality, but anyway, there's somebody's perception that boundaries, health board boundaries get in the way.
I don't think it is.
It's probably a question for Powys. We commission something like 9 or 10 neighbours, half of them in England, for service provision. And it's a commissioning conundrum at times. So we have so many pathways. One of our challenges, we need to make the pathways more simple for our patients and for our GPs. But we do then come across issues of Welsh language. Interestingly, I was recently doing some contract monitoring in South Staffordshire, and I came across more Welsh-speaking staff working in a unit in South Staffs, all came over from over the border, than I actually did have in my local mental health unit in Powys. So on my wooing campaign, I'm trying to bring them back to Wales as well. And uproot them from Shrewsbury.
In medieval times, obviously, Wales used to extend over.
That could be the other option, is how we take back Wales.
The lost lands. In the back?
Well, Chris, I'm from the Royal College of Surgeons in Edinburgh. There's a question of the club, really. Last year, our colleagues did a report standards on the rural surgery, which I'd like to share after the meeting. The question is really, to what extent do you think you learn from best practice from other places in the UK, such as Scotland?
Scottish experience of
certainly as a research centre, we're looking to link, or we are linking with colleagues in the Highlands and Islands who are working on and actually have very similar problems and challenges to the kinds that we are facing. And that, I think, from a research perspective anyway, can bring lots of benefits, partly, as you say, in terms of sharing good practice and learning, but often in terms of needing impactful research. Part of the problems we face in rural areas is obviously our sample sizes are small, and so really turning over enough people. So actually, if we can link with other rural areas and develop a much more strategic approach to how we look at the research around rural health and care, it enables us to scale up what we're doing. It enables us to demonstrate much more generalizable kind of results that we're finding. So certainly from a research perspective, yes, we're looking at we're linking with Scotland, we're linking with Lincolnshire, and a range of other opportunities.
And other parts around the world, no doubt, John.
Well, actually, there's a proposal at the moment for developing a faculty of rural remote medicine in Edinburgh at the Royal College of Surgeons. And that's kind of quite far developed. I think it's probably going to be a great opportunity because we will have access then to courses, to setting standards. Some people see it as a risk to current organisations like the Royal College of GPs. I think if we handle this properly, it's to everybody's benefit.
Great. Time is up, basically. Llai diolch yn fawr iawn i chi I gyd. Yn benodol, llai diolch I Dr John Wynn-Jones, Dr Rachel Rahman, Anna Prytherch a Joy Garfitt. Gallai diolch I bawb sydd wedi bod yn ynghlwm a threfnu'r digwyddiad heddiw. Unwaith eto yn Gwasanaeth Ymchwil mi yma yn y Cynulliad Iechyd Cyhoeddus Cymru ac hefyd Cymdeithas Ddysgedig Cymru. Diolch I chi gyd am wneud y digwyddiad bendigedig o gyffroes yma yn bosib, a diolch I chi hefyd am eich presenoldeb. Diolch yn fawr iawn I chi.